There are several factors that we consider as the resistance to hydroxyurea. Increase in white cell count while on a stable dose of hydrea, with inability to increase the hydroxyurea to counteract that increase in white cell count, is certainly a sign of a progressive disease or a loss of control. When we talk about what the benefit of cytoreductive therapy or hydroxyurea should be, we said that the control of red blood cells, white cells, spleen, symptoms, and platelets should be all accounted for, 5 factors. Well, if you don't have that, and the factors are progressing while you are on hydroxyurea, the white cell count is starting to grow up, you suddenly need to phlebotomize patients again, or the platelets are going up and people are sensitive to that, have symptoms from too many platelets, or the spleen is progressing. These are then factors of hydroxyurea failure or progressive disease, and these are factors that will lead one to change the therapy. Once we determine that patient who is on hydroxyurea is in a need of a second-line therapy, something better than hydroxyurea, we do not have a control of the symptoms of red blood cells, platelets, white cells, or spleen, these are the reasons to change, then Ruxolitinib comes to mind. It is approved therapy for patients that are not doing well on hydroxyurea, and the starting dose is 10 milligrams twice a day. Unlike its indication in a similar condition, myelofibrosis, where you have a different starting dose based on patients' platelets, here in Polycythemia Vera, everybody starts at 10 milligrams twice a day. Why do we start with what you would say perhaps lower dose? The maximum dose is 25 milligrams twice a day. We want to be safe. Expectation actually is that during the first 3 to 4 months, majority of the patients will need more. We analyzed this in the studies that led to its approval. Only about a third of the patients stays at the 10 milligrams twice a day. About 60% need more. They may go to 15 milligrams twice a day or 20 milligrams twice a day, and there are even patients that need 25 milligrams twice a day. On the other hand, less than 10% of patients need less than 10 milligrams twice a day, which would be 5 milligrams twice a day. So expectation is that you will need more, and that happens during the first 3 or 4 months, where you need to see patients more often. Ruxolitinib was proven superior to a best available therapy in a second-line setting after hydroxyurea in all aspects that we care about when we talk about polycythemia vera, which should be control of blood cell count, symptoms, and spleen. And it is a durable result. Now that we can follow patients on the phase 3 randomized studies that led to its approval for much longer, 4 and 5 years, we have a good understanding of overall benefit on quality of life and blood cell count, and even a decrease in thrombotic risk, which comes from the safety analysis of those studies. If you have control of blood cell count, you will actually control the thrombotic risk, and safety analysis of studies showed that to be the case. So the medication is very active. It inhibits biological problem in this condition, which is hyperactivity of a so-called JAK-STAT pathway. That is the pathway that is inside the bone marrow cells that leads to cell growth, uncontrolled cell growth. We inhibit the growth. We also inhibit inflammation that comes with polycythemia vera. That's why people feel so much better within a month. So anti-inflammatory and anti-proliferative effects are seen by and large in majority of the patients with polycythemia vera in a second-line setting, and it's durable and it's safe.